Okay, we're going to introduce ourselves. I'm Phoebe Cushman, and this is Chris Mulvey. And we're going to talk to you about truth or fiction, what is allowed in a methadone clinic. I am a physician at Spectrum Health Systems, where I oversee the Framingham OTP, and also our hub and spoke program for buprenorphine and naltrexone and all those other things. And in addition to that, which I couldn't fit on the slide, I am one of the consultants at MixStat, which there's a table out there. I just want to give you a shout out. It's Massachusetts Consultation Service for the Treatment of Addiction and Pain. And if anybody in this room or people that you work with have questions about patients with any of the above, no matter what setting, please give us a call, 1-833-PAIN-SUD. Anyway, that's my little plug.
Yep. And I'm Chris Mulvey. I'm a family nurse practitioner working full-time at BHN. I also work at the Dimick Center ATS, and I'm going to be working soon with an organization named Control Z. And I've worked in myriad OTPs over the years.
Okay, so we do not have any actual or potential conflicts of interest related to this presentation. And we'd like to thank Jen Babbage, Amanda Bouchard, Mike Gurney, and Heidi DeRoberto. We picked a lot of brains to put this together. I don't know if I'm tall enough to speak into my ice cream. So when Chris and I were getting together to brainstorm about what issues we're going to talk about, he said sort of offhandedly, well, really, we could talk about anything other that we do other than handing people methadone at the window, because everything else is cutting edge when it comes to methadone. So I'm going to speak kind of broadly here, and I just want to acknowledge that this is a room of kind of diverse experience. We have some people here who wrote the guidelines that I'm citing, and then we have some people who are really seasoned buprenorphine prescribers and work in primary care, but have never set foot in a methadone clinic. So I'm going to try to hit all those levels and in between. So the system we know today as opioid treatment programs was formed thanks to Richard Nixon's administration. The Narcotic Addict Treatment Act of 1974 was what gave us this siphoned off, completely separate from primary care and the rest of medical care setting, and put in a lot of the federal regulations that manage methadone. And one of the, as Deirdre also already alluded, there have been a lot of really exciting and hopeful changes that started with kind of like forced, oh my gosh, what do we do? It's not safe from an infectious disease standpoint to have people lined up in methadone clinics in the beginning of COVID, that created a lot of flexibilities that then went, and there were studies that looked at actually these flexibilities will really help people and decrease mortality and improve care. So a lot of the things that are really exciting about methadone are the take-home flexibilities and the telehealth flexibilities. But we're not talking about that today, not the two of us. We are going to just talk about all the other stuff that most of the time you could actually already do. It just can be a little confusing how to get them done. So we talk about this a lot, that we do this stuff every day. We take care of patients on methadone. When we put together this talk, we both had to dig a lot into the weeds and make sure we knew what we were talking about, which meant we were looking at BSAS guidelines and SAMHSA guidelines and DEA guidelines, and sometimes they seem to contradict one another, contradict themselves. Sometimes there's so much regulation you can't figure out how anything happens. And then sometimes you look at all three guidelines and you don't see very strict regulation about anything. And then you call Jen Babbage and say, can we do this? So there's a lot out there, and if you don't know what's going on, just speak to your the administrators in your clinics, and there's lots of people who know. And like I said, I just want to acknowledge that there are lots of real experts in the audience. So if we say something that is a little bit off, please correct us at some point. I think this was yours actually, but I can say it. Okay. So there's a real alphabet soup, and I'll just do a little overview. So methadone clinics have to be certified by SAMHSA, that's the federal government, Substance Abuse and Mental Health Services Administration. They have to be registered with the DEA, and they have to also be licensed in the state in which they operate. This is usually the DPH, and as Dee had mentioned, Massachusetts, BSAS is the part of DPH that oversees substance use services. And then in addition to all of that, they have to be accredited. And that's like somebody comes in and inspects and makes sure everything's up to snuff. And that is either CARF or the Joint Commission, formerly known as JCO. So that's all the stuff that we're looking at when we talk about regulation and what you can and can't do in a methadone clinic. So our learning objectives, finally, are first to identify the 3 institutions that regulate OTPs in Massachusetts, describe novel means of transferring methadone from an OTP to patients who are not physically at the OTP while still adhering to state and federal regulations. Number 3, review operations that allow patients to transition between methadone and buprenorphine treatment in the OTP setting. And finally, analyze the pros and cons of administering ECGs in the OTP setting. Oh, not finally. 5, compare approaches for managing addiction adjacent diseases in the OTP setting. So myth number 1, we're going to do some myth busting here. Only the patient taking the methadone can pick up the methadone. So 2 key and kind of boring concepts that you have to understand while we start digging into the weeds for the rest of this presentation are chain of custody and QSOA. So again, bear with me, it's a little boring. Chain of custody is a standard document that basically keeps track of the handling and transfer and the receipt of controlled medication. So it's really sort of focused on the DEA because they're really worried that between here and here, somebody in the middle is going to sell the drugs or take the drugs or something like that, and they want to make sure that's not happening. So you basically have these forms that say where it's going, where it arrives, who's handled it, when, how much, what's the dose, what's the date, that sort of thing. So that's a chain of custody form. And I really think of that as sort of at the individual person level. And then the other thing that we have to think about is the qualified service organization agreement. And this is at the institution level. So this is a written contract between an SUD program and an outside agency that provides services. So 42 CFR Part 2 could be its own talk, but those are the additional privacy regulations that oversee substance use treatment that are above and beyond HIPAA. So in order to abide by those, but still allow some exchange of data for purposes of like billing and healthcare and stuff like that, without having every single ROI signed by every person for everything, the QSOA is signed between the OTP and another agency that they are working with to take care of those patients. So this slide is a little busy. Okay, I'll just talk. Oh, right here. Okay. So when we talk about different ways to get patients their methadone, aside from the typical take homes, surrogacy is a big one. And really this table that I created could go on in a lot of different directions. This is just kind of like some major examples. Sometimes it just helps to think of a clinical situation that you might have. So this is true, happened in in my methadone clinic. We had a patient who had he was a previously fully functioning working person, lived with his mother, had some high-level eye surgery on both eyes sequentially, and couldn't see, right? So he couldn't come and pick up his methadone even once a month with 28 take-homes because he couldn't get there. And he couldn't actually read the bottles to administer his own methadone. But his mother lived with him. She came and met with our program director and was found to be a perfectly reliable person. So she was the surrogate. And so this is an example of surrogacy. Now, each OTP will have different sort of standards for who that person can be. Obviously, you can't just hand the methadone over to somebody, usually there's some like a meeting with the program director to just sort of have a checklist that this person can be reliable, because if the person isn't going to be able to get there every 2 weeks to pick up the methadone, that will be a problem. And also, it's not just picking up the medicine, but it's actually administering it. So for in this example, you have to make sure that the take-home bottle of the dose that you're taking matches the date and that sort of thing. So the mom of this patient was was what signed an agreement to say that she could do that. And then there's a little chain of custody form that shows which date she administered the methadone. And the chain of custody in this case is needed because it's leaving the nurses at our clinic, and then there's an intermediary person, and then there is the patient. So that's one example. So another version of surrogacy are residential programs. So in Framingham, we have several sort of highly structured residential programs. And like, for example, one of them is for women with substance use disorders and some of whom are pregnant and postpartum, some of whom are not. And so a lot of times they will have take homes in which they personally will take like they're given their box of methadone and they go to their residential program. But then once they're there, the residential program oversees all the medication. So it's behind this, medication counter, and they are essentially keeping track of it just the same way they would their other non-methadone medications. So in that setup, we would need a QSOA with the residential program because they're overseeing the methadone. And then we also, just for additional purposes, mostly safekeeping, because unfortunately, a lot of the times the people in the residential programs are sort of understaffed, maybe a little undertrained. It's really important to have extra measures to know who's taking what methadone on what day. So we have those QSOAs. So that's one version. There are other versions where, for example, instead of the patient taking the methadone to their clinic, the representative, not necessarily a nurse, but a representative from the residential program will come and pick up the methadone. So that's why I just said multiple models there. So the VNA is another model. So let's say you had that same patient I was talking about who had the eye surgery, but he didn't live with anyone and he didn't have any friends or family member that he could identify who could help with his take homes and overseeing the methadone. But the primary care or the eye surgeon identified a visiting nurse association that would dose the methadone. Now, this sounds like a pipe dream to me because in Framingham right now, we do not have any VNAs who are willing to do this, which I would say is kind of a related issue to the skilled nursing facility problem that we have, or like, and we literally, for example, right now have a patient who already has VNA services to have other controlled medications come to his home, and they're in a safe in his home that he doesn't have access to because he has serious cognitive problems. The nurse, there's already a VNA, and they said, oh yes, we're willing to do this. And now it's been 5 weeks where the QSOA is held up in sort of upper management, legal, and I guess if I try to be thoughtful about it, I do understand that it might seem kind of, from their perspective, it might seem kind of overwhelming. Oh my God, here's this fancy document with DEA and all this stuff over it that we have to sign, and it's this huge liability for our organization. But on the other hand, it's really just this extra step to do what they're already doing for the other controlled medication. So it's frustrating, and I think it's a work in progress. OTPs can actually deliver to patients' homes. So like in certain circumstances, like in the beginning of COVID, when everything was just a mess, nurses can deliver to a patient home. And there's no role for a QSOA there because there's no intermediary agency. There are specific rules about making sure that, again, that the DEA worries that nurse could drive off the road and sell the methadone. There are additional regulations, and chain of custody does help oversee that. And there are versions also in which an OTP would deliver to a facility. So one of the models. Again, the skilled nursing facility, there are multiple different models that make it possible for OTPs to work with skilled nursing facilities. In Worcester, I believe there are 3 different skilled nursing facilities that work with Spectrum's Lincoln Street Clinic. And in that situation, OTP nurses dose a bunch of bottles and then deliver it physically to the skilled nursing facility. So that involves a QSOA, and then it also, on a daily basis, when the medication is administered to the patients, it also requires chain of custody. That can also happen in a carceral setting. Sometimes, like let's say that the House of Corrections does not have its own OTP license, they can contract with an OTP. And so what I just described about the skilled nursing facility, the OTPs can deliver to the House of Corrections. That's another way, especially in the beginning when Massachusetts started rolling out MOUD in carceral settings. That was one of the ways. And some of the HOCs and DOCs still work that way. And then finally, there was actually just a nice question about medication units. Medication units actually do not require usually QSOAs or chain of custodies because they operate under the license of the OTP. So if you're a mobile unit, like Spectrum has a mobile methadone van that operates out of Lincoln Street, it doesn't need a QSOA because it's operating out of the Lincoln Street unit, even when it's going to a church and administering methadone to people there. So that is a huge, quick and dirty kind of overview, but there are lots of ways and lots of different flexibilities to sort of utilize different pathways for getting methadone to people when they can't directly pick it up themselves. So you can't get buprenorphine at an OTP. Now, why in the world is that even a myth, right? They're the two main opioid treatments for opioid use disorder. Why don't we see them more often on the same site? Well, there are some barriers to that, but it's certainly not impossible. So one of the options is dispensing methadone through the OTP, and I'll talk a little bit more about that. Another one is prescribing buprenorphine, which requires a mental health license in addition to the OTP license. And the other one is prescribing buprenorphine using an office-based opioid treatment license. So dispensing buprenorphine through the OTP is probably the easiest to do from a sort of licensing perspective because you don't need additional licenses. You're using the original like OP license, and the OTPs just modify their registration with the DEA so that they can have Schedule 3 instead of just Schedule 2 narcotics. So one of the pros of this is that patients often complain a lot, understandably, about hassles, delays, stigma in getting buprenorphine in pharmacy, and it's going to be more straightforward in an OTP. But on the other hand, people don't want to go to the OTP in the first place, which is why they want buprenorphine. So it's got some pros and cons, but there's definitely a role for it. It's also you have to be creative in order to figure out ways for the provider visits to be billed for that are usually kind of part of the process of prescribing buprenorphine. So buprenorphine can be prescribed in OTP that also has a mental health license. This is how the clinic where I work and the OTP in Framingham where I work has. So we have additional license through the DMH. If you pursue the mental health license, you have to have psychiatrists and psych NPs offering psychiatric services, which is a good thing, but it just has to do with what kind of scope of practice you want. And then medical providers can bill insurance through psychiatric codes. So you're direct billing for those visits. And that would require a CARF accreditation, which again, in the case of our Spectrum Framingham, that's what we already were using. So it made sense for us to pursue the mental health license. An alternative to that is the office-based opioid treatment license, which happens through BSAS. There's more reporting of outcomes to BSAS, and it utilizes the excellent nurse care manager model, thanks to Colleen LaBelle. I don't know if she's here, which means that a lot of great nurses are working at the top of their license, and you don't have to have as many physicians and APCs. But again, there can be some billing drawbacks depending on the setting where you work, because those nurse care manager visits can't always be billed depending on the setting in which you work. And that is a Joint Commission accreditation. So now that we have shown that you can have both buprenorphine and methadone on site in the same place, can you actually do that cool fancy thing where you used to be called microdosing, where there's an overlap between the two medications? Isn't that illegal? I've actually heard people say, oh my gosh, it's illegal. No, it's not illegal, but you do have to be careful. You can't have a person dually enrolled in both your OTP and also your buprenorphine program at the same time. So that will look a little different in different places. But for example, in Framingham, when the patient is still taking methadone, we're initiating low dose buprenorphine. They're still being seen under their, what we call their methadone episode. And then once they are fully off the methadone and onto buprenorphine, we open a buprenorphine episode. So we have sort of two programs co-located. Whether or not you can bill for those early visits while you're meeting with them and you're doing the buprenorphine induction and they're still a methadone patient, we'll let Chris talk about that in a few minutes. He got the harder questions. So that brings me to Chris. Here we go. Thank you.
All right. Yeah, so thank you very much again, and great job. I probably should have mentioned that one of my jobs in an OTP was actually launching new OTPs from the ground up. That was for the Column Health that will be in our hearts forever. And so, yeah, oh, sure, sorry, I'll do that. Yeah, so one of the next topics that we're going to talk about is treating addiction-adjacent diseases. The rationale behind it obviously is that a lot of folks actually have a lot of co-occurring disorders that piggyback on one another, particularly psychiatric conditions. Or there might be a sense of like hopelessness if they have like longstanding Hep C, and it might be kind of like interfering with motivation to pursue, sustained remission. And so we have patients that are entering care at times, as we all know, where you're either coming with like an active substance use disorder, or they're coming out of jail, or post-hospitalization, or an ATS detox. It's like a critical point for them with many challenges that they face. And they often don't have access to primary care services right away. I mean, wait times are quite remarkable. We all know that, I myself wait 6 months to see my PCP sometimes. and so, yeah, so there's this like major gap that people face, and that can have some real consequences for them, particularly as it relates to maybe even getting something as simple as an EKG to go up on a dose. So one of the interesting things that I think comes up when we're like digging through regulations and like working with BSAS, which is always so helpful, is that like the OTP license doesn't necessarily prevent us from providing a lot of care, but it also doesn't permit us to necessarily. And we both work in settings, and I've worked in many different settings where, we have an OTP license, we have an OBOT license, we have maybe even an ATS or a community-based health center. Lots of mental health licenses, and it can be a bit blurry, as Phoebe was alluding to. But we don't have, like, when we're just in a strict OTP, there's a little bit less that we're just permitted to do right away. But as I noted earlier, the best outcomes obviously come when you can address the full scope of what patients need. I would say that OTPs are an excellent place, in my opinion, like where things to be a bit different. For patients to be able to get a broader array of their care. I mean, many folks have medical trauma. They're stigmatized wherever they've been. And not only that, but it's also like you have a better rapport with people, of course, but there's also just increased convenience. I mean, there are very few places where, patients are routinely going either daily, weekly, biweekly, monthly. And so it's an ideal, point to kind of, I was going to say exploit, that doesn't sound quite right, to leverage. So yeah, Here's some like potential. This became kind of like a creative problem solving exercise, basically. It's like, so how could you possibly do this in an OTP if you're strictly OTP licensed? One would be to obtain other licenses, of course. And then there's also the option, and which we should be doing anyway, is getting QSOAs with outside community providers. But something that was interesting through a conversation with BSAST while developing this presentation was the idea came up of like perhaps a satellite office of a community health center, like in an OTP. It is theoretically possible. It would likely be, challenging to implement, but it is a possible route to highlight. And then there's another, which I think is interesting. And the caveat to this being that would have to be in keeping with boards of registration in nursing and medicine. But you can actually at least explore the option of taking advantage of the private practice model. So it's interesting in the regulations for people who are less familiar with OTPs, if a single physician owned an OTP, like just on their own, they could practice to the full extent of their scope without any additional license, right? And so a kind of a creative idea that came up that's worth exploring a little bit more is like, well, what if you engage in a relationship with a private practice physician or nurse practitioner, and that person was able to come to your site, assuming that you've been able to, protect confidentiality, and they were given a spot. They can't be your employee, right? Because then they would be an employee of the corporation and likely fall underneath those other restrictions. But if they're basically voluntarily being given space, for example, they could come in with their own EHR, their own billing system, and just use the location. And so that is something that I think is worth like looking into more. And then there's also this kind of like interesting piece where there's now like a periodic assessment billing code for OTP providers to meet with patients, like more than just getting kind of like the initial compensation from the admission and then ongoing dosing and counseling services. And so one of the things that might be actually helpful to an OTP is they might be able, like the medical director or the nurse practitioner or PA working in the OTP could meet with the patient, identify what the gaps in their treatment are, and then they could document that, maybe even diagnose, and then refer to the private practice doctor or the community-based health center satellite and use this code for their time, essentially. There are other, this is the Medicare code, but they should be aligned with Mass Health. And yeah, and so that actually might be something that's like of interest and utilizes your staff well. The next thing that I'm going to talk about is doing, electrocardiograms on site. I mean, there's like an obvious rationale for this, which is that anybody who's worked in an OTP or seen a patient transfer from one OTP to another, we've all seen patients who are continuing to use who are stuck at 120 or even sometimes 119, like just like get somebody right below a screening threshold for the sake of safety in the eyes of the person doing so. Or 140 or 150, depending upon what your organization's threshold is. First of all, the threshold is not widely agreed upon, like what the screening threshold should be. But we do know that methadone causes QTC prolongation. That could lead to a fatal arrhythmia, and it's something worth considering in all of our patients. The idea behind it is that by screening, we're reducing the risks of developing torsades point or a fatal arrhythmia from the methadone. While it makes perfect logical sense, there isn't actually a lot of good data to say that it does actually prevent the development of fatal arrhythmias. It could be just a room for additional research. The logic might play out, but generally speaking, there's weak evidence to support. And obviously, it helps with dose optimization. And then one has to also consider the other, pros and cons of increasing doses. I mean, what's more likely to kill a person, fentanyl or 10 more milligrams of methadone, and having that conversation with a patient. So some of the considerations, there's obviously just like the electrocardiogram machine acquisition. And I actually have like an alternative suggestion that's kind of interesting if that's too great a barrier. And then there's the liability concerns. It's like, I've heard many people over the years say, well, I'm not a cardiologist, or I'm not an MCRIT doctor, or I'm not an internal medicine doctor who's worked on a cards floor for a long time. I don't feel comfortable interpreting EKGs. I don't want that to be me. Which is understandable. And then some secondary considerations are basically workflow. I mean, I've worked in OTPs that are exceptionally well staffed and OTPs that have had quite a lot of turnover. Sometimes there is a medical assistant, sometimes not. Sometimes you're down a nurse and they really have to dose all day because you have 800 patients. And so I'm not going to spend a lot of time on that. But one of the things that particularly at BHN has been helpful is to cross-train staff. And so it's like if you have a medical assistant, you have a nurse, you have a nursing supervisor, you have a nurse practitioner, everybody can be trained to do it. And that way, somebody's usually free, even though it can be quite pressed, particularly in the morning. So just a couple of details, the ECG machines are oftentimes, in the ballpark of $1,500 to $5,000. This is the interesting alternative I wanted to bring up. So this is another kind of like how has COVID changed, working in methadone clinics or OTPs. So there is this device called an AliveCare cardiomobile 6-lead. And so it's an interesting little device where it's like typically you like put 2 fingers on, put it on your ankle, and it gives you a limited readout. It's very inexpensive. It's like $129. And then you have to pick a subscription service plan. So it was FDA, it was cleared by the FDA, for monitoring QTC in COVID patients. That's where a lot of the research for this came. The downside to it, there's a downside and then a really big pro. So the downside is that you have to calculate the QTC by hand right now. And so that's, I still do that sometimes, but it isn't terribly efficient. But there is like a really great option within that company's service plans, is that they actually will refer any abnormal EKG directly to a cardiologist, like reflexively do so. And it depends on which plan. I'm not going to waste more time on it, but essentially it's either 20 of them or you can request them anytime. And then you get a number of like free times per year where you can request such a consult. So that does alleviate if your organization or your providers aren't comfortable with interpreting EKGs or performing them on site. It's just a suggestion as a possible alternative. So in terms of the liability issues, so we do on-site EKGs with BHN. When we were Brightview, we were getting ready to do so. And I've worked at other organizations that, at least at the time, did not offer them. But the liability concern is the main barrier here. And so what we have is a consent form that explains the rationale behind doing an EKG on a person, and then also the limitations of what we're really concerned about. Not to say that we would ignore anything else that we might find, but we would just highlight what we're really looking for. And then we also have an EKG policy for the staff. So that's just the indications, staff responsibilities, how to execute one, indications for follow-up, and then potentially getting involved with a local community health center in order to be able to refer people who might not have like an emergent case, but might just have an urgent case to deal with. So something they don't have to go to the emergency department for, as they're already so overburdened. So there's a QR code where if you want to take a picture of it, that this is an example consent form. Just gives indications, like I said, and then there's most of it is written at like a 5th grade reading level. And then at the bottom, we just have a little bit more detail that's a bit more medicalized. That just basically says we're looking for the QTC. We're not a replacement for primary care services. We're not a replacement for cardiological care. This is what we're looking for. And then we have a policy 2, which I'll leave up there for a moment. I'm not going to read through it. But the policy does outline, as I noted before, like the purpose and the scope and indications for follow-up. So in conclusion, what we really highlighted today is that offsite delivery of methadone is possible and permissible via myriad routes. Patients can be transitioned from methadone to buprenorphine within an OTP, though there are other means of doing so rather than just depending upon your own DEA registration. The on-site ECGs are practical and they definitely reduce barriers. I mean, like I said earlier, I cannot say how many times I've seen patients who are continuing to use, and it was because they were at 120 or 140 and just couldn't or wouldn't, for whatever reason, go to another provider to get that done. And it's really, and the patients love it. I mean, they just like, they're so happy when they find out that we offer that on site because many of them have been in and out of care for 10 to 20 years and they've hit that barrier a number of times. And then, OTP regulations don't prevent us from providing services that we would like to provide. But, you might need to pursue additional licensure in order to provide the addiction adjacent care that you wish to pursue for a patient. And then we just have a number of our references here. I also just want to acknowledge our co-presenter who was not able to be here today, Angelique from New Bedford, the program director down there. She had some really interesting insights from her time in Rhode Island, and she was really helpful to us during the preparation of the presentation.